Okay, so tonight we'll do chapter 22, which is on the heart. I'm just pulling up the Canvas calendar right now so we can see where we're all at here. You have some blood pages due tonight, which is what our lecture on Tuesday was about. And then next week we'll have a lab quiz on heart structures. So anything involved or associated with the heart will be on that. And if you can see me here, this is a picture of the heart from your notes. And I'll quiz you pretty much on a picture that looks like this. So anything in this picture is fair game for that heart quiz next week. Again, I'll take structures from your lab exam 4 study guide. Speaking of the lab 4 exam, for lab, that'll be a week from tonight. And again, that's on your nervous system, the heart, and the blood vessels. There's a lot on that lab exam. If you have any questions, let me know. I did post some PowerPoints, other great ways to study, and I'm so sorry we're not in lab because this is so hard to do when we're not together. Other great ways to study are to really use your lab manuals as helpers as well. And then really, once we get through next week, we just have 2 more weeks left of the semester. You'll have your last lab exam that last day we meet in May, and then June 2nd is your last lecture exam. And we'll try to have a study session before then, maybe on Monday night or something. So I just wanted to point that out to everybody. You have all your pages there listed. So try to get those pages done and in. And yeah, we'll start with the heart then. Can everyone see my heart PowerPoint?
Yes.
Sounds good. Make sure you, okay. All right, so let's take a look at the heart, and I'll go through your notes. Again, with this unit, I really try to focus on questions that I ask you guys in lecture that I want you to focus on, those notes that I ask you as well. So this is a look at the heart, and we kind of spend a lot of time on here, especially on the anatomy, maybe before we even get to some of the questions in your notes. The heart is the center of your cardiovascular system. So after tonight, the next lecture will be on all the arteries and veins. It's nonstop pumping. It averages about 75 beats per minute. Arteries, I guess these are your first 2 on your notes. Arteries always carry blood away from your heart, and veins carry blood to the heart. So veins carry blood toward the heart, and arteries carry blood away from the heart. There's 2 instances. Most of the time arteries carry oxygenated blood, but there's 1 instance where arteries carry deoxygenated blood. Most of the time veins carry deoxygenated blood, but there's 1 instance when veins will carry oxygenated blood, and we'll talk about that. The arteries and veins entering and leaving the heart we call them the great vessels. Heart valves ensure that blood flow within the heart is unidirectional. So that if you look down Roman numeral number 8, what do the heart valves do? They just make sure that blood is flowing through the heart in one direction. If your heart valves don't close all the way and blood goes back up into a chamber it shouldn't, physicians can hear that in a stethoscope, and they call that a heart murmur, when your valves do not close all the way and blood goes in the opposite direction. They're really important because if blood's flowing in the opposite direction within your heart isn't pumping out the adequate amount of blood that it should be. So if you think about the heart like a 2 side-by-side pumps that work at the same rate and pump the same volume of blood, 1 pump on the right side directs blood to your lungs, where the blood will pick up oxygen, and the other pump on the left side of the heart directs blood to all of your body tissues, where it will deliver that oxygen. The heart generates blood pressure through alternative cycles of contracting and then relaxing, and blood pressure is just that force that blood puts on the inside walls of your blood vessels. So if blood pressure is increased, that just means more blood is flowing through your arteries. And if blood pressure is lower or decreased for some reason, there's less blood flowing through your arteries. And blood pressure is essential for circulating blood through the body. So the 2 circulation systems that we talk about within the cardiovascular system are the pulmonary circulation and the systemic circulation. And Roman numerals 3 and 4 in your notes will ask you questions. Which of these systems has deoxygenated blood and which of these systems pumps blood to all the other organs? So we'll go over pulmonary circulation first. This starts with the right side of the heart pumping deoxygenated blood through your pulmonary arteries to your lungs, where the lungs will give blood or give oxygen into the arteries. So after oxygen is picked up and CO2 is released, pulmonary veins will carry blood to the left side of the heart. So which of the cardiovascular systems has deoxygenated blood in its arteries? That's your pulmonary circulation. And I'll show you a picture of this. And then the systemic circulation is the left side of the heart pumping oxygenated blood through the systemic arteries to all the body cells. Nutrients, respiratory gases, which are CO2 and O2, and wastes are exchanged, and systemic veins will carry the blood back to the right side of the heart. So here is a good picture that kind of outlines what I just talked about. If we just go in order of blood flow, if we start with number 1 in the right side of the heart, and again, when we look at the heart, and we'll go into the exact anatomy of it, the right side of the heart is always an anatomical position. So how the heart would be in your patient. So the right side of the heart is on the right side of the patient's body. So number 1, we have deoxygenated blood entering the right side and then getting pumped out through what we call these pulmonary arteries. They are the only arteries carrying deoxygenated blood because this blood will go to the lungs where it picks up oxygen. And then the pulmonary veins, which are the only veins that carry oxygenated blood in the body, will take that oxygenated blood back to the left side of the heart. And you'll notice here the left side of the heart is now in red because this is all oxygenated blood. The left side of the heart then pumps oxygenated blood through the systemic circulation to all of the systemic cells, and then the systemic veins will carry that deoxygenated blood after the oxygen has been unloaded at the capillaries back to the right side of the heart. So that's a basic, simple overview of the circuits in the cardiovascular system and how the heart is at the center controlling the directions. So where is your heart located? It's just located slightly left to your midline, deep to your sternum in a space called the mediastinum. It's slightly rotated. So your heart kind of is slightly rotated so that the right side or the right border is located more anteriorly and the left border faces the back. The base of the heart, you can see here the base of the heart is its posterior superior surface, and that's made up of mainly the left atrium. And that's your note question for number 5. What makes up the base of the heart? We'll go through and talk about what the atrium are, but the heart is kind of sitting rotated forward, and then it sits back on itself, and it sits back on that left atrium, and that's what we call the base. The superior border is formed by the great arterial vessels and the superior vena cava. The apex is the point at the bottom of the heart, and the inferior border is formed by the right ventricle. Eventually we'll get to a picture here, I promise. This isn't the best one yet, but this shows you where the heart lies in relation to your sternum. So slightly left of your sternum. When we get to respiratory system, we'll see that your left lung has a little notch in it, or a space for the heart to sit in. So this is how your heart sits in the mediastinum, right behind the sternum. The apex of the heart is this bottom conical end, and what you're seeing here is the right border. Okay, so your heart itself is enclosed within a tough sac of tissue called the pericardium, which just helps the heart maintain stability within the thorax region. It's composed of 2 layers to this kind of sac, a fibrous and serous pericardium. The serous pericardium has 2 layers to it, a parietal and visceral layer. The visceral layer touches the actual heart itself, and the parietal layer touches the outer layer. And there's just a cavity between those two layers called the pericardial cavity, and that contains serous fluid. And again, that fluid kind of acts as a little buffer to just help maintain and keep the heart stable within the mediastinum. So here's just a look at the heart wall itself. I don't think I asked you guys questions about the layers of the pericardium, but here's the fibrous pericardium layer, and then the parietal pericardial cavity, which is just a space in between this visceral and parietal serous layers. So you can see there's a little tiny space filled with fluid kind of surrounding the heart, and then it's closed within this sac. And that's just to keep it stable and to protect the heart as much as possible. Also within the heart wall, you can see different layers. The endocardium is the innermost layer on the inside of the chambers of the heart. The myocardium is the muscular layer of the heart. And then you'll see this visceral layer is also called the epicardium, is the outer layer of the heart. So here are the three layers that we just talked about: the epicardium, myocardium, and endocardium. The myocardium will be where that cardiac muscle lies, and that cardiac muscle is what will contract to push the blood out of the ventricles when the heart is pumping blood. Another look at the layers of the heart, showing the epicardium, the myocardium of cardiac muscle. You might notice from histology way back, you can see the branching cardiac cells in the myocardium and the intercalated discs. And then again, the endocardium is just the innermost layer of the heart wall. Okay, so then we get into some external anatomy of the heart. And this will answer number 6. Let's go to number 7 first of all. Which layer of the heart wall is not composed of cardiac muscle tissue?
Myocardium.
The myocardium. Yep, so that's your answer to number 7 on your notes. We'll talk about intercalated discs in a second too. Okay, but back now to external heart anatomy, and I'll eventually show you a picture. The heart has 4 chambers inside of it. There's 2 on the top and 2 on the bottom. The 2 superior chambers on the top are called atria, and the 2 larger inferior chambers are called ventricles. So atria are on the top and ventricles are on the bottom, and they're named right and left atria and right and left ventricles for which side of the heart they'll lie on. The anterior part of each atrium forms an auricle, which looks like a kind of an extra flap of tissue on the outside of the heart itself. The right atrium will lead into your right ventricle, which leads into your pulmonary trunk, and your left atrium feeds into your left ventricle, which leads into the aorta. We have a coronary sulcus, which is a groove separating the atria and ventricles, and I'll show you what that looks like. And then we have other sulcuses. So whenever we see the word sulci, if you remember from the nervous system, that just means a groove within or between something. So we have an anterior and a posterior interventricular sulcus located between right and left ventricles. So here we have probably a great picture of the heart to start with. And I'll use a picture very similar to this on your quiz, and then there'll be one of it open so you can see the inside. But if we just start with the 4 chambers, here's the right atrium, and it's covered with this tissue called the auricle. And the auricle is the same name for your ear. Can you guys still hear me okay? I just got a message saying my internet connection was not good.
I can hear you. I'm not sure.
It's a little better. Okay. I mean, the internet connection's a little off between your mouth and what we are hearing, but it's
okay. Sounds good. Keep me posted if you lose me. Well, I don't know. Send me a message. Great. Now I got that message went away now, so hopefully we're good. So the right atrium is covered with the auricle. And remember, the auricle of your ear was the exterior part of your ear. So that's where that name comes from. It's just a flap of tissue covering your atrium. The right ventricle is right below the right atrium, and then you have a left atrium and a left ventricle. But remember when I told you the heart was twisted anteriorly so that the right side of the heart faces more towards the front? Because the heart is kind of turned and rotated in your mediastinum, which chambers of the heart are located most anteriorly? What do you guys think? There's two chambers that are located more anteriorly, and that would be the right atrium and the right ventricle. So in this picture, we can kind of see that the right atrium and right ventricle, the left atrium is more in the back, and the left ventricle makes up this smaller part because the heart is rotated slightly. So that's the answer to number 6 on your notes. The right atrium and right ventricle chambers are located most anteriorly. Let's see, we talked about sulcus. A sulci is a groove between the atria and ventricles. And then we have an interventricular sulcus between the ventricle itself. Many times within these sulci, you'll see heart arteries and veins going through them. Entering into the right atrium, we have a superior vena cava and an inferior vena cava from the bottom. Exiting out of the right ventricle, we'll have a pulmonary trunk that will branch into pulmonary arteries that take blood to your lungs. And then you have 4 pulmonary veins, 2 on either side. You can see these here. So these 2 pulmonary veins bring oxygenated blood back to the left atrium from the lungs. And then coming out of the left ventricle, we'll have an aorta that has an ascending part, an arch of the aorta, and then a descending part kind of curves back around behind the heart and travels down to the lower limbs. So this is just exterior anatomy of the heart. Here's your apex. It's this mix of this conical layer, the tip end of the heart itself. That'll give you enough to chew on for now. Let's keep going. One interesting note, the ligamentum arteriosum, it's this little piece of tissue that connects the pulmonary trunk to your aorta. The ligamentum arteriosum is a remnant of a hole that existed during fetal development when the fetus lungs are not completely developed. There's a hole that bypasses the lung. So blood leaving the pulmonary trunk will travel right into your aorta. So blood doesn't go to the lungs at all. It doesn't need to because the lungs aren't developed yet. So that is a remnant from fetal development, and then you're left with just a little piece of tissue called the ligamentum arteriosum. Okay, so your heart actually looks like this, not the one in the previous picture. So sometimes it's fun to see a cadaver heart just to remind ourselves that this is what our heart actually looks like. They say it's about the size of your fist, maybe a little bigger. So here you can see nicely the sulci, the grooves, where you'll have arteries and veins coming down through them. Okay. This is a posterior view of the back. So the back of the heart, posterior view, external structures. So this really shows how the left atrium forms the base of the heart. So the heart sits back on itself on the left atrium. Here's your left ventricle. A coronary sinus is a vein that drains out blood in the heart, and it will enter directly into the inferior vena cava, which will take the blood to the atrium. Here's your superior and inferior vena cava. You can see your aortic arch and then descending aorta come back around. And here's also a good look at the pulmonary, right pulmonary and left pulmonary arteries, and then your left pulmonary veins and your right pulmonary veins. Also a cadaver look at the heart. So here are the 4 hollow chambers again, the right atrium, right ventricle, left atrium, left ventricle. There's 4 valves within these chambers. You have 2 atrioventricular valves, which are located between the atria and between the ventricles. When they close or shut, that makes a very loud, distinguished sound, which the doctor listens for in his stethoscope. Then you have two semilunar valves, and these are at the base of the great arteries, which are the pulmonary trunk leading from your right ventricle and the aorta coming off your left ventricle. The closing of these valves make also a significant sound, and the closing of these two sounds together make that lub-dub, lub-dub, lub-dub sound you can hear in a stethoscope. And that sound, when your doctor is listening for those heart sounds, they're listening for any murmurs. So if any of these four valves are not closed all the way, they will listen for a murmur, which could be a whooshing sound as blood is rushing back into a chamber. It shouldn't be if a valve isn't closed all the way. They could also be listening for like an extra sound, an extra heart sound in there, which could mean the valve is kind of like flapping shut. So not all the way, it kind of makes a double sound. So again, doctors listening, nurses listening to your heart. They also are listening to your lungs, but the heart is just a great place to start assessing a patient because they're listening to make sure your heart works okay. So then interior of the heart, we have a lot going on here. What else do the valves do? Permitting the passage of blood in one direction. I'm not sure why I have another space for you there, because I think that's the main thing I want you to know in your notes under Roman numeral 8. If I think of anything else, I'll let you know for that. Okay, I think we've made it through the rest of the notes. So then the interior of the heart, if we take a look at the interior chambers, here's our right atrium, left atrium, and you'll notice the ventricles are the chambers with the thick cardiac muscular walls, because the ventricles are what will be contracting and then pushing that blood out the great vessels. So just a review, deoxygenated blood comes into the right atrium. What does PDA stand for, Christina?
Patent ductus arteriosus or something like that.
So can you explain a little bit what that means?
Well, so I know for hers, it was a large hole in her heart that it was pretty large, so it caused her breathing to be more labored, and she had to be on oxygen a lot more. But sometimes when, so my daughter was born a micro preemie, so she was 1 pound, 12 ounces.
Okay.
And sometimes when, like, all preemies pretty much have a PDA, and sometimes they're small, sometimes they're large, and sometimes it requires the babies to be intubated. But luckily she didn't have to be intubated. But they did like a watch and see approach. And she had to stay on oxygen pretty much the whole duration of her NICU stay. But it ended up closing on its own. And sometimes it closes on its own. Sometimes they need surgery. Sometimes they can close it with Tylenol, I hear. But it's an interesting fact that pretty much all preemies have a hole in their heart when they're born.
Yeah, patent ductus arteriosus. I think the hole in the heart is right between the atria, but I'm not sure.
I think so, because I was reading that and I was looking at this diagram to see exactly where it was, and I think you're right.
Yeah, I would have to look a little more into that. But yeah, so she was 1 pound when she was born.
Yeah. 1 pound, 12 ounces, yes.
So almost, okay, wow. Yeah, so thanks for sharing, Christina. I can't imagine going through that. Oh, I know, the longer they can bake in the oven, as we say, is the better. Yeah. Mm-hmm. So thanks for sharing, Christina. So if we look at this heart, I'm going to come back to Christina's point of holes in the heart. But if we start with just the atria again, blood enters in the right atrium via the superior and inferior vena cava. Then blood will go through this right atrioventricular valve. It's also called the tricuspid valve. So the right AV valve is also known as your tricuspid valve. And we're going to go through the anatomy of this valve, but I just want to explain a little bit right now. you can see that the valve is attached to muscles in the ventricle, and these little muscles are called papillary muscles. And the papillary muscles have strings or cords that attach themselves to the cusps of the valve. And those little strings or cords are called chordae tendineae. So we have papillary muscles that will pull or contract on these chordae tendineae. And when they do that, that will open up the valve so that blood can rush from your right atria to your right ventricle. Then the valve will close or slam shut, which again, that's the first heart sound. Then when the right ventricle contracts, blood will exit out through your pulmonary semilunar valve, which is at the base of your pulmonary trunk. And this will send the deoxygenated blood through your pulmonary trunk, through the left and right pulmonary arteries to your lungs. The blood picks up oxygen, it returns back to the heart via the left pulmonary veins on the left side and the right pulmonary veins on the right side, which enter into the left atrium. Remember, we can't see the left atrium very well because the left atrium makes up the majority of the posterior side of the heart. So now we have oxygenated blood. We're on the left side of the heart. Remember, the heart is like two pumps that work at the same time. One pump goes to the lungs and one pump goes to the rest of the body. So from the left atrium, blood goes through your left atrioventricular valve. That is also known as the bicuspid or mitral valve. And often the time a heart murmur is heard in your left AV valve. So in your left ventricle, then we have same papillary muscles, chordae tendineae, pulling on the cusps of the AV valve to open it, and then it'll slam shut. When it slams shut, the left ventricle contracts, shooting blood out of the aortic semilunar valve, which is at the base of the aorta. And the aortic semilunar valve is kind of hidden back here. It opens and blood goes through the ascending arch of the aorta and down the descending aorta. That's the mini version. There's pectinate muscles, which are on the inside of the atria. And there's also, they don't have it here, trabeculae carnae, which are ridges on the ventricles, on the inside of the ridges. The interventricular septum is the muscular wall between ventricles. And what else? They're not labeled here, but these three major blood vessels coming off the aortic arch we'll learn about in the next chapter, and they will bring blood supply to your head and your upper limbs. And the descending aorta brings blood supply to the lower limbs of the body. Okay, so back to holes in the heart. The ligamentum arteriosum is a hole in fetal development that exists to bypass the lungs, going right from pulmonary trunk to artery, aortic arch. The fossa ovalis is a tiny hole that goes between atrium, and the fossa ovalis in fetal development is normally opened as well to help blood, again, bypass from going into your pulmonary trunk, because blood doesn't really need to go into your pulmonary trunk at all. So the fossa ovalis is a hole between atrium, and usually at a baby's first breath, pressure differences when a baby takes in their first breath outside of the womb will close up the fossa ovalis with a thin piece of tissue. But when babies are born with holes in their heart, usually premature infants, when that hole in their heart is most likely this fossa ovalis that hasn't completely closed yet. So that's interior heart anatomy. There's just a lot to do with the heart. That's why there's a whole chapter on it. So as you guys are studying it, just please let me know if you have any questions. Okay. This is a cadaver view of the heart. It's a little bit harder to see things. The one thing I do want to point out with the cadaver view is just that the left ventricle has the thickest muscular walls. And that's because your left ventricle is the one that is going to be pumping heart out to the rest of the body. Okay, so here are the 4 different valves, where they're located and what their function is, for just a review for you guys. So those are the 4 valves. The nice thing about learning this chapter is you're kind of learning the same information for lecture as you would be for your lab exam. So just for fun, I include these review questions to take us back to chapter 21 on blood. What do you guys think are the characteristics of type O blood? Does anyone remember?
The E.
E is correct. It doesn't have a surface antigen A or B, so E is correct. But it does have antibodies as well.
Oh, okay.
So it does have antibodies. So it doesn't have any it can have antibodies because it doesn't have any antigens, so it wouldn't be attacking itself. So it can have antibodies, but no surface antigen. So the correct answer to this is A, B, and E.
A, B, E, okay.
So B is the correct answer for this, which you might see again. I don't know. Okay. Which are characteristics of type A blood? What do we have here?
It has anti-B antibodies.
It's against B, so that's good.
And it has surface antigen A.
It has the surface antigen A because that's where it gets its name. So B and C are correct.
Is F correct?
Yes, it will agglutinate with blood type B. So remember, agglutinate just means that its antibodies will latch on to the B and it'll cause clumping or a bad blood transfusion. So the answer to this is B, C, F. So this would be letter D would be that answer. Does that one make sense to everybody?
Yes.
Can you go back to the first question? What was I forgot. You said it was, the first one was A.
So characteristics of type O blood, it has both antibodies on it, or in its plasma. It can, because the reason why it can have both antibodies is because it doesn't have any surface antigens on its red blood cells. So yeah, so it's A, B, and E for type O blood.
Okay, thank you.
Yep. Just real quick, type AB blood is the opposite. Because AB blood has A and B surface antigens, it won't create any antibodies to attack its own cells, if that helps you kind of make sense of that. Here's type A blood. This one I underlined the answers because I didn't include this one really in our discussion from Tuesday, which are characteristics of, I think it's Rh negative, it says, of their blood. And the answers are, I can't always see the top of my screen. So Rh negative blood, it only under certain conditions will it produce its antibodies, and it'll only do that again if it's exposed to an Rh positive blood type. So it's Rh negative, so it doesn't have the Rh antigen. And this is a big one. It's inherited independently of the ABO group. What that means, if you guys have studied genetics at all, is you guys get an ABO, whatever that blood type is, in like a separate gene, as you would get your positive or negative, your Rh factor. Okay, so the answer to this is B and E, and I include those answers in there because that was just a little trickier. Okay, so back to the heart a little bit. I'm going to try to get through this. I know this is a lot of information, but there's a reason why we would normally lecture for an hour and a half, I guess. So the heart is made of dense regular connective tissue between the atria and ventricles. This helps to provide structural support and acts as an electrical insulator between atria and ventricles. Your heart is a very electrically active organ. It has its own electrical activity structure that we'll talk about. But the way the cardiac muscle is kind of arranged in the heart helps the chambers to contract and push blood where it's supposed to go. So this is just interesting to look at. The chambers around the atria, the way the cardiac muscle is arranged is that when it squeezes, it'll narrow the heart so it can squeeze the blood down into the ventricles. And the way the cardiac muscle tissue is arranged is spirally in the ventricles as well, so that when the ventricles contract, it shortens the heart. But again, that act of shortening the heart pushes the blood out. So everything is arranged to help with blood flow as it travels through the chambers. Okay, so here we have a little more information about the right atrium and where it receives blood from. I've talked a lot about this before, but this takes you through kind of what we talked about. It receives blood from your superior and inferior vena cava and the coronary sinus, which drains blood from the heart. There's an interatrial septum, which is a wall in between atrium itself. There's pectinate muscles, which are ridges on the internal side. The right AV valve, tricuspid valve, ensures one-way blood flow from the right atrium to the right ventricle. The right ventricle then receives the deoxygenated blood. There's another septum, which is a thick wall between right and left ventricles called the interventricular septum. And there are kind of irregular muscular ridges within each ventricle, and those are what we call the trabeculae carneae. Capillaries muscles within the ventricle are cone-shaped muscles. They anchor or attach to the chordae tendineae, and the chordae tendineae are just what will pull on the valves to prevent the cusps from flipping into the atria when the ventricles contract, and also to help open the valves. The conus arteriosus is a funnel-shaped region at the superior end of the right ventricle, leading to the pulmonary semilunar valve, which will take blood into your pulmonary trunk. Oxygenated blood from the lungs travels through the pulmonary veins back to the left atrium, and then your left atrioventricular valve controls flow through the left atrium to the ventricle. It's also known as the bicuspid or mitral valve. Bi because it has 2 flaps, and the tricuspid will have 3 flaps to it. And then the left ventricle pumps blood through the entire systemic circulation. It has very large muscular walls, so it'll generate a very high blood pressure. The aortic semilunar valve controls flow from the left ventricle to the aorta. And this is just a look at a comparison of the right and left ventricular walls, showing how the left ventricular walls is really the powerhouse or the stronger of the 2 lower chambers, because when it contracts, its blood has to really make it all the way through the entire systemic circulation to bring blood supply to the tissues. Okay, so coronary circulation. Okay, I know we're not answering a lot of questions yet on your notes, but we'll get to them. The heart itself needs oxygen to function. So the cardiac muscle cells need oxygen for them to contract. So how does the heart get blood? Through a series of arteries. You have right and left coronary arteries that travel within the sulcuses or sulci, which are those grooves. And these arteries can prove a problem if they're blocked. A major sign of blockage occurs in this left anterior interventricular artery. If this artery, or if your right coronary artery is blocked due to atherosclerosis, which is a buildup of cholesterol or fatty deposits within the heart or coronary arteries, when the blood vessels bringing oxygen to the heart are blocked, this is really bad. Because if your heart muscles are not getting oxygen to contract, they're not able to contract and push blood out, which your whole body needs oxygen to survive. So when a part of the heart does not get the oxygen it needs because of a blocked blood vessel, that part of the heart can become damaged, and we call that a heart attack. So when someone's having a heart attack, it's because one of these major blood vessels bringing oxygen to the heart is blocked. And that heart attack, depending on the degree of heart attack, it can actually stop the heart from contracting because those cardiac muscle cells aren't getting the oxygen they need. So here are some branches of the right and left coronary artery. And again, the left coronary artery, this branch is the most common site for blockage. I don't think that's a test question. It's just something that you might come across in your clinicals or future careers as healthcare workers. So what happens when we get a blockage in your coronary arteries? The first thing to do is to try to get rid of the blockage. So they might, heart surgeons might put in what we call a stent, which is just a thin, wiry kind of mesh. They insert it into whatever artery is blocked in the heart, and then they'll open up that blood vessel to try to allow blood to pass through to get oxygen to that area of the heart that's been damaged. You also might go on blood thinners. My dad's on blood thinners, and again, blood thinners just help blood to be really thin to get past any blocks that could be occurring. Venous return of blood from the heart occurs through these major veins. The coronary sinus is the big one that just kind of collects all the blood and then enters it into the superior vena cava or the right atrium. And then here are some more major cardiac veins that drain into the coronary sinus. I don't ask you guys a lot of details about the arteries and veins on the heart itself. A little bit of histology of cardiac muscle, and we'll answer why are intercalated discs, or what are intercalated discs and why are they important here. Let me see if I actually get to notes. I do eventually, okay. So here's a look at a branched cardiac muscle cell. It's connected with these gap junctions, and the gap junctions are made up of, well, the intercalated discs are made up of desmosomes and gap junctions. The intercalated discs just connect cardiac muscle cells together so that an electrical impulse can be sent through cardiac muscle tissue instantaneously. Here's a look at cardiac muscle cells from histology way back in February. That seems so long ago. We were actually together. But maybe that looks a little familiar. So what are these gap junctions and what are the intercalated discs? So the intercalated discs are just a part of these gap junctions. They are between adjacent cells. So remember, fibers and cells mean the same thing in muscle tissue. So intercalated discs are between cardiac muscle cells, and they just help this electrical impulse to be distributed immediately and spontaneously throughout the myocardium. And that just helps the heart to contract as a unit to be able to send out that electrical impulse everywhere at the same time. So that is your answer for number 9. Okay, so now we're getting into kind of the nervous system regulation of the heart itself. The heart can initiate its own heartbeat, and we call that autorhythmicity. This is pretty cool. So if we were to take your heart out of your body right now, think of that scene in Indiana Jones. I don't know, that like scared me as a kid. I couldn't watch it after that, but do you guys know what I'm talking about? Maybe not, never mind. Indiana Jones, where he gets his heart taken out, he's like, anyway, okay. These all make more sense when we're in person, I guess. So if we were to take your heart out, it would continue beating on its own for a while. And this conducting system, you guys will learn a lot more about this in physiology, but it starts in the sinoatrial node, which is the heart's pacemaker. It sends electrical activity to the AV node, and then that signal gets passed through the interventricular septum into what we call Purkinje fibers, which just take the electrical signal to every cardiac muscle cell. So the electrical impulse begins at the SA node, it travels through the AV node, down the Purkinje fibers, and you guys will learn more about this in physiology because it's really a physiological concept, this heart's conducting system. I can't remember if these are on your lab exam sheet or not, knowing this, but you don't have to worry about knowing how it works yet. Join me next semester if you want to know that. So this takes you through kind of what happens if there's anything wrong with this conduction system. The heart will not beat and contract as a unit, and that will start to cause problems. So this whole idea of that electrical activity passing through the heart to initiate heartbeats or contraction of the chambers, You can view this electrical activity on what we call an electrocardiogram, ECG or EKG. And this electrical activity can be measured in waves. This is a normal ECG, and we label the waves. The first wave that comes up is the P wave, and that's the electrical signal that passes through the atria right before the atria will depolarize. Whenever you see the word depolarize, that means a change in their electrical measurement. So that means they're receiving an electrical signal. So the P wave starts right before atria contraction. The QRS complex stands for ventricular depolarization, and ventricular right before your ventricles contract. And then your T wave will stand for ventricular repolarization when your ventricles go back to normal. So in number 12, 13, and 14 in your notes, let me see here. Yeah, let's go back to here. So number 12, 13, and 14, the final three in your notes, we just go down the row. In an EKG, the P wave is generated when your atria depolarize. And then number 13, in an EKG, the QRS complex is generated when your ventricles depolarize and contract. And then in an EKG number 14, the T wave is generated when your ventricles repolarize or relax. So this is extremely important. If you complain of chest pain, they'll hook you up to an EKG right away to see if the electrical activity of your heart is normal. If any of these waves are more spaced out than they should be, or if there are extra things in the waves, or if the QRS complex is upside down, you can go to school and get a certificate and read EKGs all day and have a pretty good job if you're interested in this. But hooking you up to an EKG will instantly tell physicians, nurses, medical professionals what could be wrong with your heart, and where, once they know where the problem is, they'll be able to go in and fix it by putting in a pacemaker, or by putting in a pacemaker with a lead that will bypass whichever electrical part they're having problems with. How would a blockage read? Good question, Enrique. So a blockage, it depends on where it is in the heart. And you can have blockages in arteries, but blockages in arteries are usually due to like high levels of buildup of plaque within the arteries. And that comes from lack of exercise, poor diet. But a blockage, you can have a blockage in one of those electrical nodes. So the SA node, the AV node, the bundle of His, anywhere within this electrical pathway of the heart, you can have a blockage. So anywhere within this electrical pathway in yellow here, you can have a block. So a block there would probably, a block in the AV node, for example, would give you a much longer spacing between the P and the R wave, because between the P and the R wave is when the signal should be traveling down to the ventricles. And if the AV node is blocked, it means it's stuck there longer than it should. You guys will learn about this in physiology, but it's really fascinating. It's interesting. And it's just wonderful that we can see this in hospitals, in a hospital setting, because it really helps to diagnose problems. Okay, I'm gonna keep going here. So your heart is innervated by sympathetic and parasympathetic nervous system. Maybe you guys have remembered this from the nervous system, which you already had a test on that you probably want to forget about. But let's answer the questions on number 10 on your notes. How does sympathetic and parasympathetic activity affect the heart rate? We include it here because we're talking about the heart, and it's just a reminder that sympathetic input to the heart will increase the rate and the force of contractions. So that's your sympathetic activity will increase heart rate, and the parasympathetic activity can also have an effect on the heart rate, but it's opposite. It will decrease the heart rate. It generally has no effect on the force of contraction, but it'll decrease the heart rate, so the beats per minute. So it won't be contracting as much. So that's parasympathetic innervation. A cardiac cycle are all of the events involved in a single heartbeat, and that's your final note question. I think we've covered all the note questions up to this point. So that's number Roman numeral 11. The cardiac cycle is the time from the start of one heartbeat to the start of the next. A cycle includes contraction and relaxation. And when a chamber contracts, we call that systole. And when it relaxes, we call that diastole. This is important when we get to blood pressure, which we talk about diastole and systole in the next chapter. The cycle of there's 5 steps to the cardiac cycle. And I'm just going to briefly go through them. I don't test you on this because you'll be tested on this in physiology, and you guys go through this specifically through the 5 cycles. But this is showing ventricular systole, when the ventricles will contract and blood will be ejected through the semilunar valves. This is showing ventricular diastole, which is relaxation of the ventricles. So it'll give them chances for the ventricles to fill up with blood. So you'll notice your AV valves are open during this relaxation phase as they're filling up with blood, but your semilunar valves will be closed because they haven't contracted yet. There are 5 steps of the cardiac cycle. Simply put, it involves ventricular filling, and then it involves contraction and ejection of blood from the ventricles, and then it then is what we call isovolumetric relaxation, where your atria will fill with blood, and then the atria will relax, and the ventriculars will fill up with blood again. So we kind of get this circular cycle, and all of the events involved in a single heartbeat. So that includes the chambers opening and closing, the pressure, the valves opening and closing, and also the electrical activity. We all kind of combine that into what we call the cardiac cycle. This is the last slide for tonight. How the heart ages. The next couple of body systems will go through how we're all aging. In the aging of the heart, there's decreased tissue elasticity, and that often impairs heart valve function. Some people live with heart valves, heart murmurs, not working well throughout their whole life, but often in aging, our muscles just lose elasticity, so our valves will not close all the way. So heart valve function decreases. The heart's conducting system has decreased efficiency, so that can impair the heart's ability to pump extra blood if needed during stress. And high blood pressure, which can be caused by a bunch of different things, can increase the work required of the heart, and that can lead to problematic hypertrophy of the myocardium. Hypertrophy, again, means an increase in size, and hypertrophy of the left ventricle. If your left ventricle has to pump extra hard, it'll get extremely large to try to overcome maybe high blood pressure, other blockages. I haven't seen a picture of my dad's heart, but physicians say his left ventricle is extremely large. So he's like 71, and his body's been through a lot. It's a miracle he's alive still. But anyway, that is the end of this chapter. I'm going to stop the recording